Hello.
Hi, sir. Good evening.
Hi. Where are you from?
Dr. Raghavendra from Hassan Institute of Medical Science, Hassan,
Okay.
Karnataka
Yes.
state.
How are you using OneRx?
Actually, for reference, yeah, I am using every day. It's really
Okay.
very helpful.
Thank you so much.
Thank you.
Hi, Dr. Ayuka.
Yes.
Yeah. Where are you from?
From Kenya.
Oh, that's good. So how we are
Yes.
using OneRx and how it is useful for in your clinical workflow?
This is my first time to join.
Okay.
It's my first time to join. I just got it in the Facebook.
Yes.
Then I joined the link.
Yeah.
I like the link.
That's great.
Then I joined the link.
Hmm.
So today is my first time to
Okay.
attend the meeting. So,
Thank you for joining today. Thank you for joining today's session. So we will start our session within couple of minutes. And I can see here username Samsung SMA165F. Hi, Dr. Piyush. Good evening, sir.
Hello, good evening. Good evening. Thank you for invitation. Thank you.
Sure, sir. How are you, sir?
I'm doing fine. Thank you.
Okay. Thank you for joining today, sir. And Dr. Piyush, how you are using OneRx? Can you know how it is fit in your workflow, clinical workflow?
Yeah, so lately I have been using it like
Mm.
for almost all my doubts and practice and OPD basis also.
Yeah.
So one thing I want to say that my chat GPT use has decreased a lot,
Okay.
and OneRx platform is providing the evidence based support to all the case doubts and discussions also, and
Okay.
some Indianized touch is also there. The
Mm.
availability and the whatever you have added to that,
Yes.
so it is also helpful. And from our resident times
Mm.
also, we are already habituated with the codes and Ayushman availability, and
Yes.
but it's nice to see the platform is also providing the same. And
Mm.
the tables and algorithms are now popping up in the every update, so
Yes.
it's very nice. It's very nice, I must say.
Yeah.
Thank you.
Yeah.
Thank you.
And today also we'll show a couple of other features which is available in OneRx, like a
Okay.
live demonstration.
Okay, okay, sure. I'm excited to see. Thank you.
Yeah.
Hi, good evening, everyone. Thank you for joining in. We are waiting for other doctors to join in. So we are going to give 5 more minutes till they join in. And we'll be having the session with Dr. Keval Kalvadia and Pushpendra today.
Hi, Dr. Keval. Thank you for joining. We are very
Good evening.
excited to have your speaker today.
Yeah, thank you. I'm also excited.
Thank you for joining today. And hi, Dr. Cyrus Yadav.
hello, Dr. Anish.
So let's start session now. Good evening, everyone. A very warm welcome to today's CME session, Evidence Rounds by OneRx. I'm Dr. S. Anish, Medical Advisor in Oncology at OneRx, and I'll be moderating today's discussion. It is a pleasure to welcome our esteemed faculty for today's session. Dr. Keval Kalavadia, medical oncologist from Rajkot Cancer Society, and Dr. Pushpendra Hirapara, medical oncologist from SAL Ahmedabad. Thank you, doctors, for joining us today. I would also like to welcome the OneRx leadership and medical affairs team joining today. Mr. Vivek Slaria, CEO and founder of OneRx, Dr. Suchitra from medical affairs team, and Mr. Sanjay Moria, he's a business head. So once again, thank you all for joining. Let us begin today's evidence rounds. So before we begin the case discussion, I would like to quickly introduce OneRx, a medical AI platform built for oncology and doctors, powered by Medical IQ Layer. It helps clinicians access evidence, guidelines, clinical trial data, and treatment insights at the point of care. Let's take a short look at OneRx.
protocol.
So OneRx is a medical AI platform for doctors. So at the moment, OneRx used by 1,100 plus oncologists across globally top cancer centers for evidence summary. So what OneRx gives for the doctors? So at the point of care, like second opinion, trial comparison, guidelines, schemes, and drug
And
intelligence,
6
and deep focus on oncology, medically trusted data sources. Because OneRx trained with NCCN, ESMO, ESCO, PubMed, Lancet, and other sources. And it is clinically validated with precision AI study. We got 93.3% of clinical decision impact, 97% of accuracy, zero unsafe recommendation in the study. And data privacy is important. OneRx is HIPAA, SOC2, and DPDP compliant. And I have already highlighted the trusted medical sources ESMO, NCCN, ASCO, clinicaltrials.gov, JAMA, PubMed, NEJM, Nature, The Lancet. So these are the sources we have trained this model for getting the evidence-based answer. And trust and compliance. So your patient data stays yours always. So there is zero data storage because we have ISO 2000, 27001 certified. It is globally recognized info security standard. SOC 2 compliant, independently audited data protection, and DPDP Act compliant, India's data protection law fully aligned, as well as HIPAA compliant. So this is the QR scan. If any of the doctors you have who have viewing this session, you can quickly download or quickly download or install this app, and you can also be having lifetime free access. And also, we will paste the link in the chat. You can install while doing the session also. So now I will hand over this session to Dr. Keval Kalavadia. Dr. Keval Kalavadia, over to you.
Hi, good evening, everyone. I'll be sharing my screen. Is my screen visible?
Yes, sir.
Hi. So I would like to thank OneRx team for giving this platform. I have been using it for quite some time. It is really helpful. So we'll be discussing a case per se with each other, and then we'll be comparing the discussion with OneRx, and we'll see how much helpful it is to us. Okay, so we'll be having a very common and short case of lung. If we see, there is a 58-year female who was never smoker, school teacher by profession, presented with dry cough, right-sided chest pain, weight loss, headache, and mild breathlessness since 2 months. She is known case of hypertension, while no other comorbidity is present. On examination, her echo PS was 2. As per routine checkup, we took her baseline investigations where CECT chest and abdomen suggested that there was 5.6 centimeter mass in right upper lung, lobe of lung. Mediastinal lymphadenopathy was present, and right-sided supraclavian lymph nodes were also enlarged. Along with this, both lungs were having multiple small nodules, and liver also had multiple mats, largest mat of size 3.8 centimeter, while left adrenal also had met. On doing contrast MRI brain, we found 4 brain mats with largest of 1.4 centimeter with mild perilesional edema without any shift or any history of convulsion. As per the protocol, we did a CT guided biopsy from the lung mass, which came out to be non-small cell lung carcinoma, and on IHC came out to be adenocarcinoma with TTF1 positive, NAPSN A positive, and P440 negative. As it was NSCLC adenocarcinoma, we put out for an NGS to look out for targetable mutations, and it turned out to be EGFR exon 19 deletion, along with PDL1, TPS being 80, while ALK, ROS, BRAF, everything else was negative. TP53, denoting poor prognosis, was also present. So it was stamped as metastatic CA right lung, stage 4B, with mets M1 into liver, adrenals, and brain. So the point of discussion here will be, what will be the first line of management with the patient with exon 19 deletion, along with TPS 80% PDL1 and brain mets? What would be the first line of treatment? Will we be needing an immunotherapy to be added along with targeted, or just targeted and chemo is adequate, or single agent targeted is adequate? Or do we need to do a prophylactic, not prophylactic, but whole brain radiation or SRS to the brain mets before initiating the palliative care? That will be the discussion point today. So anyone would like to join in the discussion?
So the final diagnosis came out to be adeno-CA stage 4B.
Yes.
And meds still
liver, adrenal, and brain.
Oh, at liver, adrenal, and brain. Mm-hmm.
Can I have my inputs here?
Yes, sir.
Yeah, so basically, if it is EGFR exon 19 deletion and with the liver and brain mets as well as TP53 co-mutations, so there are two ways. One is systemic treatment, another is CNS directed radiation treatment, right? So as the MRI suggests, there is a very mild perilesional edema, and if patient is not symptomatic at all from the CNS mets, the current preference would be FLAURA2 regime, which is chemotherapy plus osimertinib, though we have other options like AMI plus laser, but the availability of laser in India is itself an issue. Another option is osimertinib alone. But in presence of CNS plus liver mets plus TP53 co-mutations, I would like to add chemotherapy here for 4 to 6 cycles, and then remove the carboplatin, and then PEMI plus OC continue. For high PDL1 TPS of 80, definitely will not see, we will not add any immune checkpoint inhibitor related treatment here. As the evidence suggests, for such patients, if you give the ICI and the response might not good, and when they progress, when you add the TKI, EGFR TKI, the risk of interstitial pneumonitis is very, very, very high. So, and that is the reason sometimes when we are in a dilemma, we only start the chemotherapy and not add any immunotherapy. Even we have a PDL1 by IHC within 2 or 3 days, and if we are waiting for the NGS. So even in those situations also, we personally try to add immunotherapy if there is a driver mutation negative. So with the driver mutation positive cases, here we should not pay much focus on the PDL1, and we'll try to target the driver mutations. That is what I would like to give my inputs. Thank you.
Yeah, so exactly. As per FLAURA2 trial, we can surely start with platinum-based doublet and osimertinib. And as per the ASCO 2026, trial was done in which the patients with brain mets, metastatic NSCLC, who were not having any symptoms, in those patients, brain radiation was deferred till progression in CNS mets or till symptoms. In both the cases, overall survival was same. So instead of giving whole brain radiation or SRS to these 4 lesions, we can surely delay the radiation till progression or symptom if symptoms develop. Osimertinib surely crosses BBB, so it will be helpful. So in this cases, if it turned out to be EGFR negative and PDL1 was positive, then we would be preferring immunotherapy. So, Dr. Pushpendra, which immunotherapy would you be more comfortable using in this patient? If EGFR is wild type and PDL1 is 80%, patient same metastatic, meds to brain, liver, adrenals, and per se let's add bone as well to include the zoledronic acid if RFT is normal, otherwise denosumab if create is not good. What will be your first line of treatment in this patient?
So if patient is fit with good performance status and there are no organ compromise, organ function compromise, in that considering that situations, we have many immunotherapy options in first line. Uh, and what PDL1 TPS is 80, right? So in that situation, yeah, I personally discuss two or three options. One would be pembrolizumab with chemotherapy, that is number one. Second is atezolizumab with napaclid-carbo, or you can even eat the bevacizumab also, which is listed options, ABCP regime. Third would be you can give the Nivo plus EP plus chemo for 2 cycles of chemotherapy, and then you just continue with the Nivo EP. And the last or fourth options is only Nivo plus EP. But with a high burden of disease, as you were mentioning, I will not only jump onto the only immunotherapy part here. Uh, there are data that you can give single agent pembrolizumab also with PDL1 TPS more than 50. In my personal practice, till now, I usually combine some form of chemotherapy, at least initially 2 to 4 cycles, uh, because I have two fears theoretically. One would be hyperprogressions, which may happen in around 8, 10, or 15% of the patients, and second would be especially when there are some tumor masses which can compressing on some vital structures, like for example spinal cord or for example brain. The initial hyper pseudo progressions may, even with respect to the good response, which is probably the pseudo progressions, they may compromise or they may compress the nearby organs, and they may hamper the quality of life, or may endanger patients' symptoms. So, with this respect, practically speaking, I unless until patient is very frail, old age, and if we think that they cannot tolerate the chemo, in that recently we have very good data of subcutaneous atezolizumab, which you must be aware. So for me, some form of chemotherapy with immunotherapy, we do have 2 to 3 options which are yet listed in the NCCN, which usually considers the Western data. But then we do have some Chinese molecules or the molecules from the eastern part of India, and they have good data from their country or RCTs like tislelizumab, sertlulimab also in squamous as well as non-squamous, and toripalimab. Uh, Practically speaking, if cost is not an issue, I would discuss the NCCN listed options first with the patient. Yeah, so these are the available options.
Okay. And do you favor any drug other than Pacli and Pemetrexed when differentiating between an adeno versus squamous? Other than chemo, do you differentiate in IO for that?
So yeah, very good patients. Today itself, I had one patient, for example, let's say, so we don't, I don't find any data which suggests that for a adenocarcinoma. So your question is like, apart from squamous and adeno, where we are clear, in one we have to give the PEMI, other we are usually using the Texans.
Yes.
So if there is a adenocarcinoma, let's talk first that, right? In that situations, if there is a well differentiated or moderately differentiated adenocarcinoma, we usually start with the pemetrexed itself, right? But if your NGS is suggestive of some like kind of a TP53 or RB1 co-mutations, then I might prefer a paclitaxel, because that is kind of a poorly differentiation and early signals which suggest this lineage is going to be changed into the small cell. So I don't know, the PEMI, in that case, I might prefer a Taxan. Regarding squamous, we do have both options, Taxans and gemcitabine. People are using it. Our practice predominates towards the Taxan and the gem in the second line. But it depends on your way of practicing and how confident and you are in prescribing the drugs and managing the toxicities.
Okay. And Dr. Sahil is asking if chemo addition to the ICI reduces the occurrence of pseudo progression.
agree. But I don't have a data. I mean, I'm not aware about the data. The only problem, see, so there are two scenarios I will say. One would be clinical trial settings or academic institutions. Second would be the real world practice. I am practicing in a the private practice. I mean to say, I am a consultant in the
Community.
private. Yeah, private practice is where in real world setting you also are having a little bit fear that Pembro alone, if hyperprogress is, then there will be the things to answer. But the PDL and TPS more than 50, you are justified to give single agent. That will be totally up to the clinician's discretions.
And occurrence of pseudo progression, if we add chemo along with immuno, obviously the response or the reduction in the size will be more if PS is good, and if,
So,
as we mentioned,
so,
TP53 is there.
so there is one again hypothetical rationale that with the chemotherapy administrations, there will be a tumor cell lysis and release of antigens, which may augment the anti-tumor
Response.
response.
Yes.
Yeah, but again, that is a hypothetical rationale.
And by adding bevacizumab, does the risk of or the percentage of pseudo progression differ? Because blood vessels and everything.
Yeah. So here bevacizumab, as per the rationale, plays a role where it modulates the tumor microenvironment in particularly giving this regime. Now, practically, I or the place where we practice, we never give the ABCP frontline. Uh, but yes, there is a rational and proposed scientific background why to give ABCP regime and how they alter the tumor microenvironment and make it more immunogenic so that immunotherapy works more. Now, for ABCP regime, usually we practice a bit in the few 1 to 1.5 year back, where the patients which are progress on EGFR TKI, like osimertinib, then usually on that progressions, and if they've been treated with the third line EGFR TKI upfront, and if they progress on them, then there was some data where they used to give ABCP regime, where there was a PFS benefit.
Yes, but the risk of pulmonary bleeding was a bit more. Okay, so Dr. Anish?
Yeah.
Yeah, I will be asking the same question to OneRx.
Okay.
I'll be sharing my screen.
Sure.
And we'll be taking up 2 to 3 scenarios with OneRx.
Okay.
Is my screen visible?
Yes, sir, it's visible.
So whatever question, we can post it here and it will analyze first. I feel there is network error or something like that. Can you do it by sharing
Yes,
your screen?
I'll share you. I'll share this. Yes.
Can I ask you a question, Dr. Keval, till then?
Yeah, sir.
So for example, let's say the same situations which you were described, driver negative, okay, and you have a NGS, PDL TPS is 80. Do you feel by looking at some another mutations, your choice of immuno alone versus immuno plus chemo may differ?
Per se, as per the current data, no, sir.
Hmm.
First line will be immuno plus chemo, and if there is progression on it, then I will surely check for the mutations in the NGS report. And second line, as per the mutation is guided or as per the clinical trial ongoing, I will use the drugs. So
Thank
is
you.
is there room for rebiopsy T790M when there is a disease progression? So usually when we send a whole NGS sequencing and at that time if T790M is not mentioned, it means that mutation is not present at that point. So surely rebiopsy can be helpful. But another thing that I skipped while mentioning the case study, which I wanted to add at the last, was ctDNA report that we have written but we did not do it. We can surely use it as before or after the progression before changing the other line, in which if 790M mutation is there, then we need to change the drugs. Also we mentioned about osimertinib only. So osimertinib is helpful when there is 790 mutation. So no role of T790M at present if we are giving osimertinib itself. Yeah, so if we can see the screen, can you go up or it is still? Yeah, so as we have mentioned, as PS was 2 and fragile, they have mentioned osimertinib orally, 80 milligram with the dosage, and it is FDA approved. Trial name is also given. Other than that, fluoride 2, platinum can be added as per fluoride 2 is also mentioned along with PFS. A bit down, please. So the main problem or the main confusion we had, it notified us EGFR versus PDL1, in which they have clearly mentioned that EGFR mutated, we have to use targeted treatment, as a high PDL1 in EGFR mutant NSCLC is paradoxical associated with shorter PFS on osimertinib. Upfront ICI monotherapy is not indicated in EGFR-mutated adenocarcinoma, regardless of PD-L1 TPS 80 is measured. That is for patients who are with better PS, so it is not indicated. We should add chemo if they are tolerating it well. So in first line, they have mentioned osimertinib. And down, more down. They have also mentioned what Dr. Pushpendra said, lazertinib plus amivantamab. And as the lazertinib is not available in India, it has been on the lower side. And what I mentioned about the ESCO trial, they have mentioned that we can delay the SRS or radiation at upfront. Okay. Can you write a question that any new latest third generation EGFR available for this treatment, which is not approved by FDA or NCCN, but approved by China or Japan?
Any new latest third generation EGFR approved?
In China and Japan, but not by NCCN or FDA.
Okay, which is not FDA approved also.
Yeah.
Now we start analyzing the query intent, checking Ayushman Bharat, searching medical evidence, searching
Yeah.
EGFR inhibitors, Japan approvals, China approved EGFR inhibitors, searching medical evidence, and going for FDA approval for quick check, adding citation, preparing. So now we got 10 set up.
Yeah. Omoralitimab, yes. Key points, please. Yeah. None of these agents are approved or available in India, but omoralitimab is approved in China for EGFR T790M mutation. Phase 3 NS trial demonstrated first-line activity. Other than that, elmoneritinib is also there. And these all are there when T790 mutation is also along with EGFR. Other than Japan, no other thing, only China. Yeah, so latest things are available there.
Dr. Keval, we have two questions in the chat.
Yeah. So could we use immune checkpoint inhibitors if patient has progressed with first line of management? So after that, I would like to use amivantamab, because if we have used only osimertinib along with chemo, I would use amivantamab. Yes, after 2 lines, or yes, we can surely use if there is progression on EGFR targeted therapies. But as we said, that if it has progressed on these, the response is very poor. And about the bevacizumab, as Dr. Pushpendra said, ACBP regimen and role of bevacizumab in reduction, we can surely use it. It has been used in trials, but personally, we have not used because of 4-drug regimen being a bit toxic. So can you type if whatever we discussed, that if patient is having EGFR wild type and PD-L1 80%, if the same patient history but without EGFR mutation, and whatever doctor has asked, could you
Without
just copy
EGFR.
paste? Yeah, just delete it. And the question that has been asked by doctor, that could we use ICI if patient has just copy and paste it there. Let's see what OneRx is responding to it. You have to delete if same patient without EGFR, otherwise.
I think it started generating answer.
Yeah, stop it. There is a stop button.
Yes.
You just, yeah. And now again ask the same question, but remove the, yeah. Yeah, everything latest 2026, 2026. So as I said, despite the PDL1 being more than 80%, ICI monotherapy is not recommended. And as I mentioned, amivantamab. So yes, amivantamab can be used with chemo, which has not been used. If you have used PAM carbo in first line, you add gemcitabine in this one. And in India, these all three drugs are approved. So whatever I told you. Rebiopsy at the progression is mandatory to identify the resistance. If we have already given osimertinib, then we have to use amivantamab. If we are using afatinib, then we will shift to osimertinib. Yeah, okay, thank you.
Thank you, Dr. Keval and Pushpendra, for giving in detail clinical insights with respect to this case.
Thank
Now
you.
I will show you multiple
Can I
features which is available. Yes,
can
doctor.
I interrupt you for the
Sure, sure,
wild
sure.
guess? One question is here. What you
Okay.
can do is, and I think you must have done also, but this is just a vague thought, so I am sharing it. With respect to OneRx versus the common AI engine which is available to the general or communal public, or for example GPs. When we
Okay,
put the same question here and there, how the answers
sure.
are different, that I think you need to study. So basically that helps improving how this is particularly focused to the doctor community or oncologist community versus the one who is just doing a general AI.
Sure, sir. Let me open ChatGPT and I'll put the case. Let's see what are the key differences. Yes, sir. I have entered the same questions in the ChatGPT, and here we got the answer. And Dr. Keval, you can just see the quality of answer, like what are the comparisons between the ChatGPT as well as OneRx. Just you can give the small review on this answer.
Yeah, so osimertinib they have mentioned. They have not mentioned about Flora 2 trial, that is with two platinum based combination with osimertinib. And other than that, if we see, there is no mentioning about PFS or which trials they have compared. Everything else, it is very haphazard. If you go down, is it done?
Yes, I'm going down.
That's it. Only this much, right?
Yes.
Okay, now that is the definition of drug and everything will be there.
Hmm.
Highly sensitive mutation. Multiple brain mets is probably the strongest reason. That is not the correct way to put it up. What we can say is, as per the trial, more than 50% PDL1 is there. Then single agent osimertinib can be used. Uh, uh, Single agent osimertinib can be used, but as per Flora 2 trial, we can add Pecli and PEM and carbo along with it. And rapid improvement in symptoms is common. We have to mention percentages as well. Radiation, they have written that they have to defer, but the reason and the trials are not mentioned. So, anyways, means we need to have a backup to have a confidence on what we are choosing. So, if we see OneRx, there are a lot of backup trials along with it written in the paragraph. So we can confidently tell patient that no, we have done a research and this will be helpful to you.
Thank you, sir. Thank you, Dr. Keval, for conveying the comparison between the OneRx as well as the ChatGPT. So I will show you other features what you can use in daily clinical workflow. So if you have entered the total patient details and biomarkers and all the symptoms and what have to start chemotherapy or which have to start by radiation or all the queries we have discussed in this session. But here we have a clinical trial options. So this clinical trial future, how it will be used in clinical workflow. So a patient can't be affordable for taking any chemo regimen because due to the cost factor. So, but if any clinical trials is conducting in any other state, in any other place in country or any institute, so doctor can refer this patient to this clinical trials and patient can get affordability for getting the treatment. So now what happens here after clicking the clinical trials, it takes almost 30 to 40 seconds for detecting or analyzing the clinical trials which is ongoing and recruiting in India as well as the globally. And we can see how this patient can fit into this clinical trial. And also we can see there'll be lots of inclusive criteria, exclusive criteria, whether this patient is matching in this criteria or not. And also who and how can register to these clinical trials, like principal investigator and contact details for clinical research teams. So everything will be getting in the clinical trial sections. So it takes few seconds for generating the clinical trials. Yeah. Let it load for some time. I'll show you the patient section. So this is the patient section where we got lots of feedback from many of the oncologists. So here, what clinicians can do here, we can enter the patient. Let's take Sumit. So then we can upload multiple files of the patient case files, PET-CT scan, radiology reports, and whatever the scans which is available with respect to the patient, we can upload all the files. So after submitting here, it takes few seconds for generating the answer. Let me show you already uploaded one. So here I have already uploaded one of the NGS report of this patient, Sumit. So this is the NGS report of myeloid NGS bone marrow sample of age 73 years old male, and the sample is positive for clinically relevant variants. And we got the genomic alteration, total depth VAF, variant classification, and also we got all the biomarkers, genetic alteration with the therapies, which is the guideline one. So what happened here after uploading this report? Here there is add note section. So in this file, there is no comorbidities. So I have entered the patient is diabetic. What happens here after entering the AI summary, it immediately gives the master summary. So first, immediate attention required. What clinician have to see for the patient for confirming the final diagnosis, and what are the considerations have to take, and total summary of the report of this NGS panel, as well as the latest lab reports. So here lab reports I didn't enter, so here we got no lab reports available in this document, and what missing information is available. So next steps. So right now we have just preliminary report. So what next steps I have to take for getting the final diagnosis? So after that, uploading here, so I have entered the patient is diabetic. Now I need to ask what is the line of therapy. So here you can see there is two options. There are the two things. One is document which I have uploaded, as well as the patient is diabetic. So here the AI got full context of this patient. Now it start analyzing the query intent. Now it goes for the medical advice, medical evidences, clinical trials, and larger trials which is available in the sources. We will get the quick information in few seconds. So here line of therapy for this patient, we got as per NCCN guidelines with Indian context and with the document findings. You can see here which I have entered the NGS report. It clearly picks the NGS report, and we got the line of therapy, first line treatment, second line treatment, and post line treatment and monitoring. So here we are discussing regarding the treatment as well as the drug part. So monitoring is very important, as you know already, and what missing information. So the patient also have to do these type of tests for confirming the final diagnosis. And we need ECOG performance status and diabetes detail I didn't enter it properly. So uh, we can enter everything in the notes section regarding the patient comorbidities. So this is the one part. Just a second. So here we have the clinical trials. Yeah, here it's loaded everything. So previously I have discussed regarding the clinical trials. So whenever we have entered all the patient context regarding the NGS panel and the biomarkers and everything, so now it start analyzing the clinical trials, which is actively recruiting in India as well as the global. So, with respect to this patient, there is a study is ongoing, a phase 4 study of venetoclax in combination with azacitidine in Indian subjects with newly diagnosed acute myeloid leukemia who are ineligible for standard induction therapy. So, this trial is actively recruiting at the moment. So, this trial matches with this patient. And here we can also see why this trial matches. So the patient MDS is progressing, has transferred to ML, and this regimen could provide disease control with less intensive approach. The patient current management context already includes azacitidine and venetoclax considerations. And also we can see eligibility criteria, use versus exclusive criteria, and in Indian sites where all the trial is ongoing, currently recruiting. So here we can see. So and also we can see the sponsor AbbVie pharma company, they are sponsoring this trial, so we can refer this patient for this trial. And There are other trials already completed, this terminated, and these are all the international trials. So this is one of the coolest feature which we have. You can use in your daily clinical workflow. So this is regarding the patient section. And next, discover. So think of newspaper. So daily we will be opening newspaper and we'll see the headlines. So what happening in the real world. So the same scenario we have done here. So at the moment, I'll go for the oncology and I click for 1 month. So there are lots of FDA drug molecules keep on updating on daily basis, as well as the NCCN guidelines also updating on daily basis, and many clinical trials gets updated. So what happens if we click this 1 month, 7 days on today, we will get all the updates in one page. We can see here key FDA updates FDA approves sacituzumab govitecan HZ as monotherapy and with pembrolizumab for first and triple negative breast cancer and FDA approves palbociclib added to trastuzumab without pertuzumab plus endocrine therapy for maintenance in HR positive and HR2 positive metastatic breast cancer and FDA approved belzutifan plus with the for the pembrolizumab with or without parahyaluronidase alpha PNPH as adjuvant renal cell carcinoma therapy and FDA approves capecitabine with abiraterone and prednisolone for metastatic prostate cancer in a P10 deficient context. These are the FDA updates in this month, and we got the clinical trial updates and other updates, which is really important for the clinicians. So these are all the oncology therapy area. You can go for the quick newspaper read on daily basis. And these are all the stories. So we know PubMed is the largest medical store. There are crores of articles will be published in yearly basis. So to stay updated, what we have done, if any research article got published on daily basis, so we will be getting as a stories. So just I will click this first one. It will redirects directly to the scientific reports and article, and you can see here published 9th July 2026. That is today. So this is how we got updated on daily basis, and you can see all the research articles and FDA approvals. So everything will be in one place in Discover option.
Yeah, thank you, Dr. Anish. So I want to ask all of the doctors who have joined in, do you have any questions for us on the platform, OneRx platform? We are very happy to answer. And do all of you have the access of the platform? You can speak, you can type in the chat. Okay, no questions. Over to you, Anish.
Yes.
I have a question.
Sure.
Yes.
Can you upload this app on the Play Store so that you
It is
enter
on Play
or
Store.
just
Yeah, it is on
Play
Play Store.
Store?
Yes, yes, it is on Play
Yes.
Store.
Just write one RX, then you get it.
OneRx. Yes.
With the logo.
Logo will be RX.
RX.
Yes.
Yes.
Sure.
Can you show the scan? You can see.
Yes, yes, I'm sure. I'm sharing the
Uh,
scan.
let's open the Play Store page. Thank you, Dr. Piyush. Yes, that is under the consideration to launch it under the Windows App Store. So this is the QR code. You can scan it and download it, or simply go on App Store, type OneRx, and you can upload it. I'll also drop my contact number in the chat. If any of you have any difficulty, any questions, feel free to drop me a text on WhatsApp. I'll be very happy to talk to you.
Thank you.
Thank you. Hi, Dr. Mosa. I see you want to ask a question. Let me unmute you. Hi, do you have a question, Dr. Keta? Do you have a question for us?
Bonjour, how are you?
Hi.
Good afternoon. Good morning.
Good evening. It's evening time, but good morning to you too. Are you
Ouais,
using OneRx?
ouais, yeah. Ouais, English, small English.
Okay. Would you have any questions for us?
Oui, si, France, oui.
Okay. So Dr. Anish is presenting his screen. You can scan the QR code and download this app.
Mhm. Good formation, c'est franchement good for you.
Thank you.
Bon, comme, ouais, même en traduction française, ça aussi, c'est impossible aussi.
Dr. Anish, I think let's wrap up the session. Okay, done.
Thank you so much for all the doctors today for joining, and thank you for our expert faculties, Dr. Keval and Dr. Keval, for showing the comparison between OneRx as well as the ChatGPT. And thank you for Dr. Pushpender for joining the session and giving clinical insights with respect to the cancer. And we will be happy to meet you for next session. There will be evidence round, or there will be next week. And we are welcoming to join us again to this platform. Thank you for all. Have a good night.